So thank you for the invitation to present to you today. My talk is going to be on physical activity during cancer treatment. And my name is Emer Guinan, and I'm a physiotherapist by background and an associate professor in cancer rehabilitation and survivorship in Trinity College Dublin. So when I think about physical activity during cancer treatment, really to set the scene for today's talk, I went back to the Physical Activity and Cancer Control, or PAC framework. And this was published in 2024. It was an update on the PEACE framework, which many of you may be familiar with. The PEACE framework was originally just the top line of this particular image, which outlined that physical activity can play a role throughout the cancer journey. And it was updated in recent years to really show the growing body of research and literature that we have in this space. So when we look at the during cancer treatment phase of this new PAC framework, we see that they're really talking about these two key areas here, that physical activity plays a role in treatment preparation and coping, and also in treatment effectiveness and coping. And these are in the domains of the pre-treatment, so just preparing somebody as they go in for treatment, and the during treatment phases. And there's lots of different outcomes here that are relevant. So in the pre-treatment phase, we're really looking at kind of delaying any kind of complications or avoiding treatment complications with that. During treatment, we're looking at treatment completion, treatment efficacy, tumor biology in the microenvironment, some really interesting areas of research ongoing in that space. And as with, I suppose, physical activity throughout the cancer trajectory, we expect physical activity during treatment to have the same positive effects on physical health, mental health, psychosocial well-being, and quality of life that we see in other areas. A lot of these programs are delivered in the clinical setting because patients may be unwell as they go through treatment, but through triage models, we may be able to get some patients out into the community as well. And that's good for both the health service, but also for patients in terms of being able to access some of these services. So my talk today is really divided into those two areas. I'm going to talk first about treatment preparation or coping, and then we're going to move into treatment effectiveness and coping. So when I talk about treatment preparation, I'm really talking about this concept of prehabilitation. And many of you on the call today will be very familiar with prehabilitation. Prehabilitation is a really attractive concept. It is this idea that we can optimize or improve a patient's condition in advance of their treatment starting in order to help them cope with the treatment that is to come. And this image here that I've shown is taken from that top reference there, Durand and Singh in 2019. And it really is your classic prehabilitation framework. It links back to the Macmillan prehabilitation guidelines as well. And it's that classic concept that when somebody is diagnosed, they come in with that baseline level of fitness. And with prehabilitation, we can make them fitter in the lead up to treatments, typically surgery, okay? Whereas if patients don't get prehabilitation between their diagnosis and their first treatment, their fitness will more or less stay the same. When patients go into treatment, so when they have big surgeries or when they have really cytotoxic treatments such as chemotherapies, we do expect elements of physical health such as fitness or muscle strength to decline. And they will decline whether or not patients have prehabilitation or not. But what we see in the prehabilitation arm is that I suppose that magnitude of decline is blunted. It's not as bad. They don't hit the same level of low that you would see in those who do not have prehabilitation. And this is a concept here that we try and blunt the impact of these really harsh treatments on patients by getting them ready before they go in. This paper really talks about, and the whole Macmillan prehabilitation guidelines really talk about the prehabilitation rehabilitation continuum or pathway. And in the ideal, we would like to think that once treatment is over, that we are rehabilitating patients back again, so supporting their recovery. And we can see here the different pathways that are demonstrated with rehabilitation and without rehabilitation. And I suppose the real optimal one is in those patients who are lucky enough to get prehabilitation and then rehabilitation afterwards, that in the ideal, we would be able to bring them back up to a level of fitness or a level of activity or a level of strength that actually exceeds their baseline to support them then as they go on to living with and beyond cancer. So this is the concept, and very visually, I suppose, describes that concept of what we mean by prehabilitation and why it's so attractive as a concept in cancer care. There's no, I suppose, one universal definition that we all fall on for prehabilitation, and that's okay. But there's lots of descriptions out there of what prehabilitation is, and a lot of them tell us the same thing. So the very first one that came out in 2013 described it. Julie Silver has done a huge amount of work in this area in America. A process on the continuum of care that occurs between the time of cancer diagnosis and the beginning of treatment. It includes physical and psychological assessments that establish a baseline functional level, identifies impairments, and provides targeted interventions that improve a patient's health to reduce the incidence and severity of current and future impairment. So this definition really leans on the fact that we know an awful lot of cancer treatments cause impairment. And if we can get measurements completed on patients prospectively or as they go through treatment, we can measure where people start at baseline. We can measure the impact of treatment on known impairments and bring in interventions early and proactively to mitigate that decline. So it reduces the incidence and severity of current and future impairment. And I think that resonates a lot, particularly with physiotherapists who are joining today. The Macmillan 2020 guidelines then, so this is from their Principles and Guidance for Prehabilitation within the management and support of people with cancer. These are currently being updated in the UK, but they have a really nice definition here as well. They describe prehabilitation as something that enables people with cancer to prepare for treatment through promoting healthy behaviours and through needs-based prescribing of exercise, nutrition, and psychological interventions. Prehabilitation is part of a continuum to rehabilitation. We saw that in the diagram I showed you in the earlier slide. And the aims of prehabilitation are to empower patients to maximise resilience to treatment and improve long-term health. So this Macmillan definition takes it a broader view, moves from just outside impairment to looking at that concept that prehabilitation can include lots of different modalities, exercise being one of them. Promoting the prehabilitation to rehabilitation continuum, but still has that core concept that we want to maximize people's health in order to help them withstand treatments that are to come and long-term recovery. So what are the potential benefits? Well, the first thing is to improve physical health to endure or become eligible for cancer treatment. So I've done a lot of work in upper GI cancer. So if you think about somebody going for an esophagectomy, if we can improve their fitness before going for surgery, the concept is, or the hypothesis is, that they will be able to better withstand post-operative recovery. In the ideal, we would like to see that they have lower incidence of post-operative complications such as pneumonia, but also that their physical recovery and their ability to engage in rehab, ERAS, and mobility, post-operative mobility in those early days post-op is better, that the recovery may be better. So that's the ideal, that we would optimize somebody before big surgery and improve their immediate post-operative outcome. There is another role here, of course, as well, because we know that the fitter patients are going into surgery, the less the lower their risk is of post-operative complications. And as somebody's fitness declines or is lower, their risk of post-operative complications then increases. And at a certain point, it becomes a question, well, is this person fit enough for surgery? So there is a role for prehabilitation in taking people with very low levels of fitness and increasing that fitness to a level where you move them from being at a very high risk of post-operative complications to a much lower risk that maybe the surgeons and anaesthetics are much more comfortable with. So that's your first potential. Your second one then is around improving psychological health to cope with diagnosis and impending cancer treatment. And we see psychological benefits of exercise, for example, but we also see psychology as a key pillar in prehabilitation. We don't have an enormous amount of evidence, and services aren't rolled out internationally as much as we would like, but certainly intuitively, the more psychologically prepared somebody is going in for surgery or big treatments, the better they'll be able to cope with that treatment. So it's very much an evolving area of research. Prevent treatment-induced toxicities and improve treatment completion and recovery. And this speaks back to that whole concept of post-operative complications that I spoke about in the surgery setting. And we'll talk a little bit more later in the presentation about the role of physical activity during treatment to manage some of the immediate toxicities and side effects that can occur with treatments such as chemotherapy. And then one of the really, I suppose, exciting areas of research is this concept or this hypothesis that exercise or physical activity can influence tumor biology and the microenvironment directly to improve treatment efficacy and delay the need for treatment. And again, I'll speak about that more in the coming slides. So where is the evidence on this? So we have lots of feasibility studies that look at, well, can we exercise patients in that really stressful period of time between diagnosis and commencing surgery? Will they adhere? Can we do it? Really short, intensive interventions are probably needed there. So we've lots of those types of studies, and we have lots in lung cancer as well. But what we don't have are a huge volume of big randomized controlled trials. So we've lots of smaller randomized controlled trials, but not as many big ones as we would like. And these are some of the more recent systematic reviews, scoping reviews, meta-analyses that have been conducted in this space. And they all kind of come down to the same thing, that we need, from a trials perspective, we probably need more big randomized controlled trials in this space to really prove efficacy. Of course, I would describe prehabilitation sometimes as maybe a little bit of a victim of its own success, because in many countries, surgeons and anaesthetists are very on board with prehabilitation. And that's wonderful. And they're very supportive of prehabilitation programs being rolled out and implemented in their settings. And that makes it very difficult to run a high quality randomized controlled trial where you have a control arm who does not receive any prehabilitation. So it's very intuitive. It makes a huge amount of sense, and clinically patients see and health professionals see lots of very positive outcomes. So I wouldn't let the evidence base in terms of the randomized controlled trials and where we need to go and maybe generate some more be a deterrent here to supporting the concept of prehabilitation, because it is very difficult where we are now to justify why you would have a control group that shouldn't receive prehabilitation in the lead up to big treatments. Of course, prehabilitation is difficult. The idea of prehabilitation is that you exercise somebody from the time they're diagnosed right up to maybe a big surgery that might be their first line of treatment. It's very, very stressful for that patient. We're also talking about, physical activity as a risk factor, as we heard in the first talk, for certain cancers. So we may be dealing with patients who haven't exercised as per normal as part of their routine before they were diagnosed with cancer. So you're trying to introduce something very new. The other big thing are the timelines. There are KPIs, and surgery has to be completed within a set number of days from the time of diagnosis, and those KPIs need to be met. So it's a challenge from both a research point of view and from an implementation point of view. And this is an image from a piece of work that was led by one of my really good PhD students, Emily Smith, where she looked at the acceptability of prehabilitation. So is it worth it? Like, is all of this push that we're having, is it being accepted from patients and from health professionals on the ground? And she used a theoretical framework to inform this. And really her results were very interesting, because while it's acknowledged that there's a burden associated with prehabilitation on patients and on families and on health providers trying to deliver those resources in a stressful setting, it is very much seen as an intervention that is worthwhile and that should be promoted, and that efforts should be made to implement it. And from all of her work and all of her findings, some of the key clinical implications are that introduction of services should be comprehensive and clear and right there from the start. It should be very patient-centered, understand that's a high stress time that they're going through, and prioritize accessibility for all. And then finally, that services do need to be appropriately resourced within a clear referral pathway, so that it is very easy to embed it within current models. So I suppose while it's difficult, I wouldn't let that be a major deterrent, that we really do need to be pushing this, that patients and health providers are supportive. Real world considerations, of course, it's not possible for everyone to see, resources are stretched. How do we see everybody? There's a model in Manchester, Prehab for Cancer, and has been very, very successful. And they use this kind of triaged or tiered approach. And a lot of us are using this kind of approach across cancer care at the moment, where we recognize that some patients have a higher burden of need or higher burden of complexity, and they need more specialist input and oversight into things like rehabilitation. Then we'll have those that just need a little bit of extra support, but maybe not as I suppose the level of supervision they may need to be less. And then we've got universal programs that will suit a lot of patients who are otherwise doing well and don't have a huge amount of complexity. And this kind of tiered approach might be something that we consider when we think about implementing prehab programs that are sustainable. The other thing to mention is that in the ideal, rehabilitation doesn't just involve physical activity or exercise. It is one component of that and often provides the kind of steady framework for rehabilitation programs. But in the ideal, we're looking at incorporating nutrition, psychological support, and also education programs that focus on other risk factors such as smoking cessation or alcohol consumption. But of course, that's rehabilitation as we prepare patients for big treatment. What about during treatment? So I'm going to move on to the treatment effectiveness and coping phase of the presentation now. This is a guideline that was published in 2022, yes, by ASCO, the American Society of Clinical Oncology. Now, ASCO is the big international organization from where all of our clinical oncologists get their guidance on best practice. Okay, so for ASCO to publish this guideline has huge impact for us in the exercise oncology world. They recommend that oncology providers should provide aerobic and resistance training, exercise training, during active treatment with curative intent to mitigate side effects of cancer treatment. Exercise interventions during active treatment reduce cancer-related fatigue, preserve cardiorespiratory fitness, physical functioning and strength, improve health-related quality of life, reduce anxiety and depression in some populations, and have low risk of adverse events. So concerns are alleviated. So this is really important. This is getting the oncologists in particular behind the exercise community in terms of promoting physical activity during treatment. So what are the benefits? And there's a huge amount of ongoing work in this space. So I'm actually just going to start at point 5 because this is where we have a lot of randomized trials. And we know that there are lots of benefits to exercising during and after active treatment that promote physical well-being, psychological outcomes and quality of life for patients. And I would say that we have very, very strong evidence from clinical trials to support that. Some of the areas then of emerging interest are, well, we observe better outcomes in patients who can maintain their physical activity during and after treatment. And why is that? What are some of the biological mechanisms underpinning that? And points 1 to 4 really speak to this. So it is hypothesized that exercise can have a direct effect on tumor growth and metastases through lots of different pathways that we can that are being investigated at the minute. Is it through pro-inflammatory pathways, immune suppression, etc.? Improved treatment completion rates, and we have a number of trials in this space which have really looked at exercise during adjuvant treatment, particularly chemotherapy, and have described that patients who complete particularly aerobic and resistance training exercise have higher completion rates of chemotherapy in comparison to those who do not exercise or who maybe just complete aerobic exercise alone. That resistance exercise has an important role to play here. And that's really important because if we can support patients to complete their chemotherapy to a higher level, that's good in terms of the impact that that chemotherapy can have. There are trials, these are emerging trials, and we don't have a critical mass of literature in this space, but it's one hypothesis that's been tested repeatedly. Improve treatment efficacy. And this is, I suppose, the really novel area of research that's ongoing at the minute. So this is particularly driven through what we would call angiogenesis, or the ability of cancer tumors to generate their own blood supply. And normally when tumors do this, the blood vessels that they generate are kind of leaky and porous and don't function very well. With exercise, the integrity of the structure of those blood vessels can be improved, which reduces hypoxia or improves oxygenation to the tumor, but ultimately improves chemotherapy delivery to the tumor. And this is the area that an awful lot of groups around the world are looking at the minute. Can we improve chemotherapy delivery through the tumor through improved angiogenesis of the tumor? Through exercise programming during cancer treatment. So I'd say watch this space to see the emerging literature that comes out in this area. And then management of treatment-induced toxicities, such as cancer-related fatigue. So we know that inflammation is something that exercise can target, and by reducing inflammation through exercise, that can have a knock-on effect on things like cancer-related fatigue, which is higher with higher levels of inflammation. So we see all of these, the state of the evidence, I suppose, summarised in the ACSM exercise guidelines for cancer survivors. This was published in 2019. We have really strong evidence from clinical trials across a number of different outcomes: anxiety, depression, fatigue, health-related quality of life, and perceived physical functioning, all improved with aerobic, anaerobic, and resistance exercise. And we have emerging evidence in a lot of these spaces down at the bottom. So I talked about treatment tolerance in particular there, but there are other areas ongoing, such as cardiotoxicity and chemotherapy-induced peripheral neuropathy, etc. So these are, I suppose, areas that I keep an eye on these trials. We may see an update into this in the next iteration of this roundtable. But of course, exercise during treatment is really tough. And anyone working clinically with patients will be like, how do I do this? We looked at, I suppose, the implementation challenges of exercise trials during treatment. And this is another PhD student of mine, Neil Kearney, and he did some really nice work here. And looking at the trials that have already been completed that are providing us with the evidence in this space, we see that patients prefer, have higher recruitment rates for home-based exercise programs. So they prefer home-based, but retention on those trials where they don't have that in-person support tends to be trickier. So we need to balance there. We get higher adherence for aerobic exercise than for resistance training exercise, and that can often be what patients are more comfortable with, but we know that resistance training exercise is very important in this group, so that's another challenge. What we also see is that exercise programs lack periodization, so they lack almost a planned application of clinical reasoning, that while patients are going through chemotherapy and they're feeling unwell after certain cycles, and then they may feel better the following week, exercise programs need to follow that pattern, need to work with patients so that they're flexible in how they schedule programs. And an awful lot of the trials that are published already lack diversity, so in terms of basic demographics, but also in terms of cancer type. So we need to learn more about an awful lot more cancers to really be able to implement this into practice. One of the big things that we're running now, that Neil is running in St. James's, is the FIRST trial, which worked with patients and other healthcare providers to design a very flexible type of program, which is very, very patient controlled. So allowing flexible scheduling of exercise programming during chemotherapy, patient controlled in terms of the level of intensity that they want to reach, maps to their treatment cycles, and is based on their own symptom monitoring to provide them with the control and the understanding of how they can exercise in the context of having lots of different cancer symptoms. So our protocol for that is published. So we'll see how that program works for patients as we analyze results towards the end of the year. So I'd like to thank you for your attention, and just flag that we have a lot of resource and a lot of service mapping done on www.cancerrehabilitation.ie, where you'll find more details to follow on from today. So thank you very much.